I think it's 9:30, and I'd like to pass this over to Dr. Ken Culver, who is our Director of Research and Clinical Trials, and let him introduce Dr. Alice Shaw.
It's a pleasure to be here and look forward to meeting each of you individually. It is my pleasure to introduce a woman who's been involved in why you're here. She's from crizotinib to ceritinib to alectinib to brigatinib to lorlatinib. She's been one of the leaders in the US and globally for bringing those to reality, which we know has changed the outcome for ALK patients substantially. But the work's not done yet, and she continues to see patients and continues to labor as an employee at Novartis, looking at other ways in which we can target the ALK protein and move us from what's looked a chronic disease state to a cure. I had the privilege of meeting Alice in about 2013 when I had the privilege of becoming the US lead for the ceritinib development, which played a really critical role in the gap between crizotinib and alectinib's approval. And I know that she still has this passion and dedication to helping to change the life and the outcomes for people with ALK-positive lung cancer. And it's my pleasure to invite Alice to tell us what's coming next as we begin to move towards our cure for this disease. So welcome, Alice.
Thank you so much, Ken. And I hope, hopefully everyone can see and hear me okay. I first wanted to thank Dan, Brittany, Nancy, Lana, Kirk for all your hard work. Really so impactful for this community. And of course, I want to welcome everyone, say hi to everyone in the room, also everyone who's online. I do want to thank the ALK-positive organizers for inviting me to give this keynote. It really is an honor and a privilege for me to be here and to see all of you, even virtually, and to be able to share my perspectives on the field of ALK-positive lung cancer. The last time I presented actually at this ALK Summit was 3 years ago, and so much has changed, not just for ALK, but I would say for the broader landscape of cancer therapeutics. And so I'm really excited to be here to share what's new in ALK, also what's new outside of ALK, so that we can think bigger and broader, and what I'm referring to here is thinking outside the box, in order to have even more effective, more impactful treatments than what we already have today. Okay, so here's the agenda for the next 30 minutes or so. I'll start with a brief background on the history of ALK and ALK-targeted therapies for those of you who may be newer to the ALK community. I'll then focus on the third-generation inhibitor lorlatinib or Lorbrena, and the latest update that we have from the phase 3 study, the CROWN study of frontline lorlatinib. That was just published a few months ago, and I think it really does solidify the role of lorlatinib in the first-line setting for newly diagnosed ALK-positive patients. And after that, we'll focus on novel and emerging therapies, starting with the 4th-generation ALK inhibitor from Nuvalent, NVL-655, which was developed to overcome on-target ALK resistance mutations. But then really the bulk of my talk is going to focus on really new strategies and technologies that could potentially be applied to what we call off-target or ALK-independent resistance. And I've selected what I think are 3 very exciting emerging technologies or platforms that are currently being developed outside of ALK-positive lung cancer, but I think really hold a lot of promise for ALK, particularly in the context of orthogonal combinations. I'll come back to this concept in a little bit. And then in the last 10 minutes, we'll open the floor for Q&A. And of course, there'll be plenty of other opportunities today and tomorrow to ask additional questions of the ALK experts who I know are there in person. All right, so just to remind everyone, almost exactly 16 years ago, Hiro Mano's team in Japan published this seminal finding of ALK rearrangements in lung cancer in the journal Nature. And in this single paper, they described the underlying chromosomal inversion that leads to the most common ALK rearrangement, EML4 ALK, and also demonstrated that the resulting ALK fusion is oncogenic and likely confers sensitivity to ALK tyrosine kinase inhibitors or TKIs. So really defining ALK as a new and targetable subset of lung cancer. And really setting the stage for the development of multiple generations of targeted therapies that have transformed the field of ALK-positive lung cancer. So really an absolutely pivotal discovery. And remarkably, very soon after that report, in fact, within about 4 months of the publication, we started testing the first ALK inhibitor, crizotinib, in the clinic. And many of you already know this history, so I'm not going to review it again, but this slide just highlights how incredibly sensitive ALK-positive lung cancers can be to ALK inhibitors such as crizotinib. And this was one of our very early patients on the phase 1 trial of crizotinib. And by the time we did his testing and found that his cancer had an ALK rearrangement, you can see on the left CT scan that he had really extensive and also very symptomatic disease in the lungs. But typical for ALK, he had a phenomenal response to crizotinib with near complete resolution of all of his disease, as you can see on the right. But while we saw many dramatic responses just like that, we also started to see pretty early on that patients were relapsing due to resistance. And often this occurred after just less than 12 months even. And this is what really fueled the search for and the development of more potent ALK inhibitors, starting with the second generation ALK TKIs, ceritinib, alectinib, and brigatinib, and more recently, the third gen CNS penetrant ALK TKI, lorlatinib. And shown here is the timeline of when these first and next generation ALK TKIs were approved by FDA, highlighting how quickly this field advanced, with a total of 5 ALK inhibitors approved in a period of just about 7 years. So a major question facing the field has been, how do we optimally sequence all of these ALK TKIs? And, historically, many ALK patients received ALK inhibitors in the order in which they were developed. So moving from first to second to third generation TKIs at each relapse, as you can see here. In 2017, we presented the results of the global ALK study, and that ALK study showed that in the first line setting, alectinib significantly improves progression-free survival compared to crizotinib, and this led to an almost immediate shift in the treatment algorithm, with second generation ALK TKIs basically replacing crizotinib as frontline therapy. Just 4 years later, in 2021, we presented the results of the CROWN study comparing lorlatinib with crizotinib in the first line setting, and we showed an even greater benefit with frontline lorlatinib, leading to a slow but gradual shift now towards lorlatinib as the first-line treatment for newly diagnosed ALK-positive patients. Now, just a few months ago, we presented an update, as I mentioned, to the CROWN study, and I wanted to share that with you today because, as I said, this really does reinforce lorlatinib as probably the most effective first-line treatment. And so shown here, just to remind everyone, is the study design of the CROWN study, comparing lorlatinib head-to-head against crizotinib in newly diagnosed ALK-positive patients. At the time when we published the first analysis of CROWN, the median follow-up of patients with lorlatinib was about 18 months. And now in this updated analysis, the median follow-up of patients is about 3 years. So as you can see here, after 3 years of follow-up, the median progression-free survival with lorlatinib, this is frontline lorlatinib, has not been reached. And you can see here in the small little print that 64% of patients at 3 years are still without progression. And of course, in contrast with crizotinib, less than 20% of patients are without progression at 3 years. This is a really striking difference that translates into a reduction in the risk of progression or death of 73%. Now, in the global ALK study, which I just mentioned, that compared alectinib with crizotinib, and median progression-free survival was 26 months, with a reduction in the risk of progression or death relative to crizotinib of 50%. And so really, I think some evidence, it's indirect, but some evidence that there is greater benefit with lorlatinib compared to alectinib when we compare to crizotinib in these two separate phase 3 trials. But for me, what's I think especially important about the CROWN update is the data with brain metastases. And I think everyone here in the audience knows that for some reason, ALK-positive lung cancers do have this propensity to spread to the brain. And this can be very problematic for patients. And, in fact, lorlatinib was specifically designed by Pfizer chemists to penetrate the brain in order to address this issue. And so here what I'm showing is time to CNS or brain met progression with lorlatinib versus crizotinib. And I think, as you can see by that blue line, which represents lorlatinib treated patients, this line is almost flat, indicating that very few patients have CNS progression on lorlatinib. In fact, if you click just once, I highlighted this point that in patients who don't have brain metastases, if you don't have brain metastases at diagnosis, then treatment with first-line lorlatinib leads to a 99% chance of remaining free of brain metastases at 3 years. And this is pretty extraordinary, given the CNS relapses that we've seen on alectinib and brigatinib, and it really does suggest that lorlatinib can not only treat brain metastases effectively, but can also really protect the brain from metastatic spread. But even with lorlatinib used frontline or used after prior ALK-TKIs, we know that resistance still looms. And almost all of our patients at some point will develop resistance. And so resistance is a large research focus of my former group at MGH, as well as many groups around the world. And we've learned a ton about resistance over the years. And it's so much that it's actually really hard to summarize in one slide. But one of my former fellows and now colleagues, also an ALK expert herself, Jamie Schneider, was able to capture the most important mechanisms of resistance in this one figure, which we published in the journal Nature Cancer earlier this year. So we'll work off of this slide. I would say probably the simplest type of resistance to understand is what we call on-target resistance that involves genetic alteration of ALK itself. Most commonly, this is a mutation. And then once that cancer acquires an ALK resistance mutation, the ALK-targeted therapy, the TKI, can no longer bind and inhibit the kinase, and that leaves the ALK kinase then active and able to drive tumor growth. A second major class of resistance is what I called earlier off-target or ALK-independent resistance, and that involves activation of alternative signaling pathways or bypass pathways. And these pathways are activated through genetic or non-genetic mechanisms, and they really do bypass the need for ALK signaling. And then on the far right, there's a third major class of resistance. It's actually quite rare in ALK-positive lung cancer, but it is important to note. And this is histologic transformation. And that's when the cancer actually changes its histology, what it looks like under the microscope, typically from an adenocarcinoma to a small cell cancer or a squamous cell cancer. And that's in the setting of becoming resistant to an ALK-TKI. Now, I think we've made, where we've made the most progress in terms of research and translation into new therapies is for on-target resistance, so what's shown on the left. And in previous summits, I've talked about how common single ALK resistance mutations are after alectinib or brigatinib. It highlights how after sequential ALK-TKIs, probably about 20 or 25% of patients can develop these double or compound ALK mutations that are really refractory to lorlatinib. These tumors we know with compound mutations are still usually driven by ALK. It really has highlighted the need then for a fourth generation class of ALK-TKIs that can target these specific compound mutations. So fortunately, there are at least 2 fourth-generation ALK-TKIs that have entered the clinic for ALK-resistant patients, one of which I've shown here. This is Nuvalent's NVL-655. On the left, it's shown the potency of different ALK inhibitors, including 655 against various BAF3 models expressing different ALK mutations. For the 3 ALK G1202R double mutations kind of in the middle of this figure, you can see by the red shading that most of the available ALK-TKIs really lose activity, against these compound mutations. However, as you can see by all the green shading in that blue box, 655 retains very potent activity against both single and compound ALK mutations. And then consistent with this BAF data in vitro, 655 is also really active in vivo in PDX models of ALK-resistant cancers. This is shown on the right side. This is a PDX model from MGH that harbors both the G1202R mutation as well as the gatekeeper L1196 mutation. So really encouraging preclinical data, and I'm really excited that the phase 1 dose escalation study of 655 is progressing well in the clinic. Okay, so returning to this slide that summarizes resistance mechanisms. Again, if you just click the slide once, I think there's really no question that off-target resistance is really the greatest challenge that we're facing in the field here. And while those patients with compound ALK mutations may benefit from fourth-generation ALK-TKIs, most patients actually don't have these compound mutations, and instead their cancers have acquired these off-target resistance mechanisms, and sometimes multiple different off-target resistance mechanisms. Now, sometimes we do identify genetic drivers of off-target resistance. So, for example, MET amplification, which we've highlighted here, that's a well-established off-target mechanism, and that can confer sensitivity to combined ALK and MET inhibitors. But I would say in general, we often can't identify a genetic alteration that's mediating off-target resistance. And then even when we do, combination therapy, as some of you know, can be really difficult from a safety and a tolerability standpoint. And that then leads us to dose reduce the drugs. And that then prevents us from really being able to dose at efficacious levels. And so a really challenging, unfortunately, common situation that we're encountering in the clinic. And so this is one where I really think we need to think beyond simply combining targeted therapies. This slide captures where I think we do need to go in terms of the next wave of therapeutic strategies for ALK-positive lung cancer. So, in addition to inhibiting the underlying oncogenic driver itself with the most potent ALK TKI, I really think we have to think about orthogonal therapeutic strategies. And here, by an orthogonal therapy, I'm talking about treatments that kill ALK-positive cancer cells, not by targeting ALK or a downstream signaling pathway, but by a totally different mode of action. And there are actually many different orthogonal therapies we could consider, but I think given the limited time today, I thought I would focus on three examples of really innovative new therapies that have already had an impact in the clinic, and I think could be potentially leveraged in a combinatorial approach for ALK-positive lung cancer. So from left to right, we have antibody drug conjugates, or ADCs. In the middle, you can see radioligand therapies, or RLTs. And then on the far right, immune cell or T cell engagers. And so for the last maybe like 20 minutes or so, I'm going to walk through each of these examples somewhat quickly, because I just want to give you a flavor of what's on the horizon, outside the ALK TKI space. Okay, so let's start with antibody drug conjugates, or ADCs. These are antibodies that recognize a cell surface protein that's selectively expressed or highly overexpressed on cancer cells compared to normal cells. And these antibodies are typically chemically linked to a cytotoxic chemotherapy, what we sometimes refer to as a payload, or here a warhead, which should really kill the cancer cells. And so by targeting cancer cells, these ADCs should allow the selective delivery of the chemotherapy to tumor cells, and hopefully spare normal healthy cells. And one of the most exciting ADCs that has made a big splash in the oncology space is one called trastuzumab deruxtecan, or Enhertu, which targets the growth factor receptor HER2, which is expressed in a large proportion of breast cancers and some other cancers as well. And I thought this particular cartoon drawing might be helpful to illustrate the mechanism of action of ADC. So again, if you start on the left, you can see that the ADC, you can see the ADC here with the antibody that's linked to the chemotherapy. The antibody portion of the ADC binds to the HER2 target, which is expressed on the cancer cell. And then the ADC is internalized into the cell, where now the cytotoxic payload, that chemotherapy, is released and it destroys the cancer cell. Now, some of the cytotoxic payload can be released from the dying cancer cell, and that can actually kill nearby cancer cells. And this is a phenomenon we often call bystander killing, and it can increase the efficacy of the ADCs. Now, in the context of breast cancer, Enhertu is already approved for patients with HER2 expressing breast cancers, and shown here is just one of the recent studies comparing Enhertu head-to-head against standard of care chemotherapy. The activity of Enhertu is shown on the left, while that of standard chemo is shown on the right. And I think you can appreciate, just looking at this slide of these waterfall plots, that the ADC on the left induces more responses in patients and also a greater depth of responses than standard chemotherapy. And in fact, the responses with Enhertu, this ADC, are also significantly longer than what we can achieve with standard of care chemotherapy. Now, there are a number of other ADCs that are also in development, and for several of these, we actually have some data from the clinic in ALK-positive patients. And so shown here is the ADC called datopotamab deruxtecan. I'll just refer to this as Dato, which targets this glycoprotein on the surface of cancer cells called TROP2. And again, you can see the antibody here on the left, which recognizes TROP2, again, linked to a cytotoxic payload, a cytotoxic chemotherapy. This happens to be the same one as on Enhertu. Now, datopotamab is undergoing a lot of clinical testing in non-small cell lung cancer and other tumor types. But what I wanted to share with you specifically is the data that's been presented on this ADC's activity in patients with oncogene-driven lung cancer. And so this was the phase 1 Tropion pan-tumor 01 study that enrolled patients with metastatic cancers, including 34 patients with lung cancers harboring an oncogenic driver. Most commonly, it was EGFR, but there were also 9 patients on this study with ALK. Now, I should note that these patients were not selected based on expression of this ADC target TROP2. Now, what this waterfall plot shows is that datopotamab induced responses, or at least tumor shrinkage in the majority of patients. And I've highlighted the 3 ALK-positive patients who had measurable disease. You can see them sort of encircled here by the red boxes. And all 3 patients did have a decrease in tumor burden, including one here on the right, who managed to achieve a real response, a confirmed response at about minus 60% tumor reduction. So it's a limited data set, but I think it's pretty encouraging. And then here's another ADC that I wanted to mention briefly. This is patritumab deruxtecan, targets HER3. This is a related tyrosine kinase receptor to EGFR and HER2. It's expressed across many different solid tumors. And here, similar to Enhertu and datopotamab, patritumab includes this antibody, of course, targeting 3, a linker, and then that same cytotoxic payload deruxtecan. So shown here is preliminary data summarizing the clinical activity of patritumab in oncogene-driven lung cancers. Again, I'm highlighting the 2 ALK-positive patients who were treated with this ADC. And here you can see that both of the ALK patients achieved a response to patritumab, and including one patient with a response that was ongoing beyond 18 months. So again, a small data set, but I think quite promising. And so I borrowed this slide from Bob Lee at Sloan Kettering because I think it's a nice high-level summary of the many antibody drug conjugates that are in clinical development for lung cancer. I touched on just 3 of the ADCs that are shown here, but as you can see, there are many others. And I think we're going to see more clinical data emerging in the coming months to next few years, and that includes data in ALK-positive patients. But the main point I really wanted to emphasize is that the cell surface proteins, that are targeted by these antibody drug conjugates may be expressed on ALK-positive lung cancers. In fact, almost certainly some are. And so we should consider how to leverage these ADCs for ALK-positive lung cancers, and in particular, in combination with ALK-targeted therapies, especially as ADCs should be better tolerated and hence more combinable, given that they're targeting tumors selectively. So let's move on to the second new technology, and I want to be upfront here that, Novartis, where I work now, has been pioneering this technology, and we're quite excited about this. And this is radioligand therapy, or RLTs. Now, in principle, RLTs are very analogous to antibody drug conjugates in that there is a tumor targeting vehicle that's typically a small molecule or a peptide instead of an antibody. But that's linked to a payload. And in this case, of RLT, the payload is not chemotherapy, but instead it's radiation therapy, which I think most of you know, radiation therapy kills cancer cells by damaging DNA. I would say, just to summarize RLT in a nutshell, RLT really enables tumor-targeted delivery of radiation therapy. And so, unlike traditional external beam radiation therapy, RLT can actually target both macroscopic disease, what we can see, but also microscopic disease, what we can't even see. And also RLT can target not just local disease, but actually widespread disease. And so now I wanted to highlight that, RLT is distinct from ADCs and other therapies, and that here we actually first select patients most likely to respond based on molecular imaging that shows expression of the target. Now, how we do this is summarized here, and just in brief, patients will first receive what we call kind of a counterpart of the RLT that's linked to a PET or a SPECT isotope, such as gallium-68. They then undergo what's a PET scan, basically, to determine whether their cancer expresses the target. And if so, then they receive the RLT linked to a therapeutic radioisotope that emits either alpha or beta radiation that, of course, is damaging the DNA and killing the cells. Typically, patients receive 4 to 6 doses of RLT every 6 weeks. And at the end, the patient can undergo both standard CT imaging as well as repeat PET imaging to assess the response to the RLT. Next slide. And so to date, 2 RLTs are now approved for cancer patients, with the most recent one being lutetium PSMA 617 or Pluvicto for patients with metastatic castration-resistant prostate cancer. And shown here is just kind of a cartoon illustrating the mechanism of action of Pluvicto, where you can see that Pluvicto binds specifically to this gene called PSMA, which is a prostate-specific cell surface protein. It's then internalized, exposing the cellular DNA to beta radiation and causing tumor cell killing. Like ADCs, RLTs can also induce what we call that bystander effect, killing nearby cancer cells. Next slide. And so in a phase 3 study that was published in the New England Journal of Medicine, we showed that in men with late-stage metastatic castration-resistant prostate cancer, Pluvicto was superior to standard care, improving not only radiographic progression-free survival, but also overall survival. And this ultimately led to FDA approval of Pluvicto last year. Next slide. Importantly, I think for us, we've shown that Pluvicto also significantly delays time to worsening in terms of quality of life and pain, which it's really so important in these patients with late-stage disease. And here you can see that Pluvicto was, again, superior to standard care in delaying the progression of prostate cancer-related symptoms, such as pain, which, of course, you can appreciate can have a huge impact on quality of life. Next slide. So shown here is just an example of how effective Pluvicto can be in some patients. This patient had very extensive metastatic prostate cancer with diffuse bone metastases, bone marrow involvement, and lymph node metastases as well. And after receiving 6 cycles of this RLT Pluvicto, he underwent repeat imaging, which showed this really dramatic response and improvement in all sites of disease. Next slide. So just as with ADCs, there are now multiple RLTs in development, going after different targets, different indications, and using different radioisotopes as well. Shown here is the RLT pipeline of a biotech called Point Biopharma, where you can see the different RLTs at various stages of development. And again, I want to emphasize one point, if you advance the slide once, that again, the targets that are being explored for RLTs may be ones that are expressed on ALK-positive lung cancers. And I would also note that RLTs have generally been really well tolerated without the toxicities of cytotoxic chemotherapy or ADCs, again, making them potentially very combinable with targeted therapies such as ALK TKIs. Next slide. Okay. So in this last section, I just wanted to touch on the immune system and how we might harness the immune system to kill ALK-positive cancer cells. And I think everyone here probably already knows that, unfortunately, checkpoint inhibitors such as Keytruda and Opdivo have really limited to no activity in ALK-positive lung cancers. And multiple studies have shown this over the years, including this one prospective study of the PD-L1 inhibitor durvalumab in EGFR ALK-positive non-small cell lung cancer, where, again, if you just advance the slide once, I've highlighted that there were no, if you just click once the slide, you can see that there are no objective responses observed in ALK patients. Next slide. I think many here are aware and eagerly awaiting the ALK vaccine that Roberto Chiarola and Mark Awad have been working to develop. And again, just to remind you, this vaccine is based on ALK peptides, so portions of the ALK protein that can induce ALK-specific immune responses. And shown here are some preclinical data from a very recent publication this month, demonstrating how potent the vaccine is in combination with lorlatinib and a checkpoint inhibitor. And also on the right is shown how there's potential for the vaccine to even help prevent brain metastases in this preclinical model. And so lots of excitement and hopefully some good momentum to advance this vaccine into the clinic. Next slide. But what I wanted to focus on are new immune cell or T cell engagers that can redirect and even reactivate the immune system to kill cancer cells. So here on the left is, again, a simplified cartoon drawing illustrating the mechanism of action of bispecific T cell engagers. And so these are antibodies that have been engineered to bind to the TCR, the T cell receptor complex component CD3, and at the same time to bind to a cell surface target protein on a cancer cell. And this basically brings T cells into close proximity of cancer cells and thereby redirects their activity toward the cancer. Now, this field and this technology has been moving so quickly, and we now even have next generation tri-specific T cell engagers, which you can see on the right, which have been designed to not only redirect T cells, but also to enhance T cell activation to more effectively kill cancer cells. Next slide. Now, there are already many examples of T cell engagers approved in various hematologic malignancies like myeloma and lymphoma. And I would say that progress has been a bit slower in solid tumors with these bispecific or T cell engagers, but we are starting to see some really promising clinical data and a few indications. And so I'll show you just two examples. This first example is a bispecific T cell engager targeting a cell surface protein on small cell lung cancers called DLL3. In early phase clinical trials, this DLL3 bispecific induced a response rate of about 23%. But what I think was particularly notable to us is that these responses were really durable, lasting about 12 months, as you can see here on the bottom right in this swimmer's plot. Next slide. Now, many key targets expressed by cancer cells, though, are not on the cell surface. And so a new class of biologics, these are called bispecific fusion proteins, have been developed. They're actually referred to as ImmTACs. And this is a lot of detail on this slide, but basically I just wanted to say that these bispecific fusions involve recognition of targets presented on the surface of cancer cells as peptide HLA complexes. And then again, through CD3, they're able to redirect T cells to selectively kill cancer cells. And so this is really a new technology that could expand immune cell engagers to many more targets and many more cancer types. Next slide. And as an example of this, I'm showing here tebentafusp or Kimmtrak, which is the first ImmTAC approved by FDA. Here, Kimmtrak targets a melanoma specific antigen, GP100, and binds specifically to a GP100 peptide, so a portion of GP100 that's complex with HLA on the surface of melanoma cells and recruits T cells through CD3. And in a phase 3 study of patients with uveal melanoma, which really is a terrible disease, which doesn't respond to really any therapies, including checkpoint inhibitors. But here, tebentafusp was able to improve overall survival compared to standard of care, and this led to FDA approval. And so, these bispecific engagers are really exciting. If you advance just quick once, I summarized here that the emerging results, I think, in solid tumors do suggest that even in PD-1 insensitive or non-responsive tumors, there may be a way still to redirect and reactivate the immune system to kill cancer cells. Next slide. Now, before closing, I just wanted to take a moment to reflect on these new advances and what it will take to bring any of these into the ALK space. And I think that without a doubt, what we need is continued research, focused on ALK-positive lung cancers, because only through this research will we really understand the underlying biology and the vulnerabilities of ALK-positive tumors, and then be able to expand beyond targeting ALK itself. And as I said right from the beginning, we have to think beyond ALK and develop new drugs with completely different modes of action from ALK TKIs. And so, efforts like the Enigma study led by Jess Lin and Justin Gaynor, and many other efforts that seek to define the genomics, the proteomics, the immune landscape of ALK-positive lung cancers, efforts that actually all of you are helping to fund. I mean, these are absolutely critical to drive the next wave of therapeutic strategies. And so thank you all for supporting and believing in the research. Next slide. And so in summary, we now have 4 generations of ALK TKIs. These have truly transformed the treatment landscape of ALK-positive lung cancer. However, no matter how effective our ALK TKIs are, resistance seems to inevitably develop at some point. We know that ALK resistance mutations can often be overcome. They can even probably be prevented by third and fourth generation ALK TKIs. However, this ALK independent resistance is a major challenge for the field. And I would argue that, the mechanistic combinations that we've been exploring in the clinic haven't yet delivered, the efficacy and the safety that we had hoped for. And so clearly new treatments are needed. And I'm really excited about some of the latest advances, which I shared today, ADCs, RLTs, immune cell engagers. And I think that, with this expanding therapeutic toolbox, I think the treatment paradigm for ALK will evolve over the coming years. We'll focus a lot on upfront treatments, maximally cytoreducing with the most potent ALK TKI, but then also coming in with an orthogonal treatment to really eradicate any residual or persisting disease so that we can actually prevent resistance altogether. And then just that final plug for continued research, defining the genomic landscape, the immune landscape, the cell surface proteome, of ALK-positive lung cancers. We need to know what that is to really leverage these technologies. And I really do think these new technologies will bring us hope and bring us really closer to the cure. Okay, so with that, I know this was a whirlwind, but I'm going to stop here and I'm going to turn it maybe back to you, Ken, to do some Q&A. Thanks, everyone, for your attention.
Dr. Shaw? Oh,
Yes, now I can hear you.
Thank you. Thank you. My name is Mark Muskovich. I'm a member of the medical committee, and I have a couple of questions from the chat.
Okay.
One question is, and I think it's on many people's minds, if an individual is stable on alectinib at present, should they change to lorlatinib?
Thank you for that question. I have to say that's a really, really commonly asked question for obvious reasons, right? Because alectinib is incredibly effective, was established as the first line standard of care. And it's only more recently that we now have this lorlatinib data. And I would say that this is a tough one because we don't have clinical trial data to guide us here. But I would say that in general, for me, I take sort of the question and this decision about alectinib or lorlatinib kind of on a case-by-case basis, factoring in, of course, each patient's personal preference. Also, of course, I would say important factors are how patients have been doing on alectinib in terms of response and also side effects, because alectinib can have some side effects. Also, I take into account whether or not patients have brain metastases. And just to maybe illustrate, I mean, there's so many different scenarios, as you can imagine, because every patient has their own story. But just to illustrate, two extreme scenarios, if I see a patient who's been on alectinib for 3 years, doing great response, really barely any side effects, no brain metastases, I actually would lean toward continuing them on alectinib. They clearly have alectinib sensitive disease. There are no tolerability issues. And many of us who've been in the field for a long time have a lot of ALK patients who've been on alectinib long-term, 5, 7 years and beyond. And, I would want patients to have that potential opportunity to stay on a well-tolerated drug if they have no evidence of disease. And then on the opposite extreme, I do see patients who, if they were recently started on alectinib and they have brain metastases at diagnosis or really just extensive disease. I mean, for those patients who are more recently started on alectinib and have these other kind of, I would say, risk factors, I would consider that in that situation, making a switch to lorlatinib, because as I showed you, just that activity in the brain is so pronounced with lorlatinib, and we do want to use our maximally active therapy to cytoreduce as much as possible. The last thing I might note before turning it back to you is that the side effects of alectinib and lorlatinib are quite different. And so I definitely factor that into this discussion and decision. And so I think alectinib generally is well tolerated, but can have fatigue, definitely can cause anemia over the long term. Lorlatinib, everyone's quite familiar with the neurocognitive and mood side effects that can occur in some patients. And so we have to kind of, when I talk with patients about this idea of a potential switch, I do really take into account those side effect profiles and what patients are able to tolerate.
Okay, thank you. Thank you for that thoughtful answer. A second question that's come from the chat is, when we have the ADCs and the RLTs in hand now, and as they're better developed, is there hope that they can provide a more likely arrival at a curative therapy? As
Yes.
opposed to TKIs?
Well, I wouldn't say as opposed to. I think what I was trying to highlight is to explain what these technologies are and how they're allowing us to really develop tumor selective delivery of either chemotherapy or radiation therapy. But I think what we've learned over the years is that probably to really deliver the longest, most durable remissions, and potentially that sort of shot at cure, we really need to build combinations. And so I think these technologies are really exciting. They already demonstrate activity on their own. But where I'm hopeful we'll go with these new technologies is in the setting of a combination. And what I said at the very end, which I probably might have said too quickly, but I think what many of us in the field envision is that we would sort of integrate these technologies together. So we know how active ALK-TKIs are. We're never going to move away from those, but we can hopefully enhance the activity further by integrating in these orthogonal treatments like ADCs and RLTs and immune cell engagers. And one sort of scenario that I had mentioned very briefly in that last slide is that, again, in the future, one could imagine that perhaps the ideal or optimal treatment for a newly diagnosed patient with ALK-positive lung cancer might be to start with the ALK-TKI, see that great response. And then again, we know from many years of research that even though we have that great response, there is likely still some residual disease or even micrometastatic disease that we really can't see. And there, to try and eradicate that, I think we do need to come in with one of these different orthogonal therapies, such as ADCs or RLTs. I think that approach, where you bring together these orthogonal treatments, maybe 2 different, maybe 3 different orthogonal treatments, is what's going to give us the best shot at cure.
Okay, thank you. And then one last question in the last 3 minutes from the chat is, will RLTs, ADCs, and ICEs be subject to resistance in analogy to the resistance to TKIs?
Yes, that's a fantastic question. And I think that is what we've learned again over the years, that any sort of single therapy, a targeted therapy, a chemotherapy, even checkpoint inhibitors, yes, cancer cells, because of their sort of underlying instability, their ability to change and mutate, they almost always will be able to overcome a therapy that's just given by itself, right? So a chemotherapy given by itself, cancer cells we know develop chemotherapy resistance. And we've already talked a lot about targeted therapy resistance. And so, yes, I would say that if we use them by themselves, just like an RLT by itself, that would not be sufficient. We definitely need to build that into a combinatorial strategy.
Excellent. Well, Dr. Shaw, thank you for your encouraging presentation and the excellent discussion. We appreciate your time.
Oh, thank you all.